All right, welcome everybody to our stream this afternoon. It's such a pleasure to have you here. Today it is my supreme pleasure to welcome Dr. Bethany Brandt, a renowned researcher in the field of dissociative identity disorder and other dissociative and trauma-based disorders. Dr. Brand, would you mind introducing yourself for us?
Not at all. And I understand that we are live, just so everybody understands that too. I'm
Yes.
a professor at Towson University. Um, I do a lot of research on trauma-related struggles, mostly dissociative disorders. And I also treat patients in a practice, and I do some forensic work as well. So I'm honored to be here.
And it is a pleasure to have you. So we're going to start off with a basic question. What is dissociation and what causes people to dissociate?
All right, dissociation is when somebody is experiencing what are normally integrated functions of their mind not being integrated. So some examples might be that rather than feeling their emotions, they don't feel their emotions. Rather than feeling connected to their body, they don't feel connected to their body. It could also be a number of other things that are disrupted. It could be memory, their sense of who they are, all kinds of things, their perception of the outer environment can be disrupted. And it is generally understood to be, well, there are some examples where people without trauma, without stress, can experience dissociation, such as during a peak athletic performance or a very intense spiritual experience. But what I specialize in and what we're going to talk about today is trauma-related dissociation, which means that when a person's been absolutely overwhelmed by some incredibly stressful experience, such as trauma, that's when they begin to dissociate, disconnect from themselves. And if that happens severely enough or often enough, they may dissociate after the trauma as well.
Okay. And how can one help oneself out of dissociation?
So if somebody's really bothered by how much they dissociate or what happens when they dissociate, they can work on what's called grounding. So let me give you an example. When somebody I work with, maybe they tell me that they're driving and they don't feel connected to themselves and the world around them looks very uh, fuzzy, foggy, something like that, then I would teach them how to do grounding, which is there's lots of ways of doing it.
Mhm.
But one very common way is to use your senses to recognize what's going on right in the here and now. So for the client who might be driving, I'd say pull over safely. Um, and then when you're safely pulled over, then begin to use your eyesight and describe to yourself or out loud, if it's okay, wherever you are to do that, 5 things you can see and in a lot of detail, like, all the richness of the color and the details. And then 4 things you can touch, some things you can smell, taste, hear. All of the senses like that help the brain to get the parts of the brain that kind of start going offline, so to speak, with dissociation, help them get more back online.
Mhm. Wonderful. Um, what causes dissociative identity disorder?
As best we understand it right now, it is early, very significant chronic child maltreatment. Often there's also attachment problems. So, as infants and very young children, we all need to feel a sense of connection, bonding, attachment to safe caregivers. But if somebody doesn't have that and they have nobody that feels safe to them, nobody that helps them when they're really
Mhm.
scared, for example, maybe they're more prone to it. We also know that there is a genetic contribution of some sort that, that's still being worked out. But the one big underlying theme is very early significant childhood trauma.
How prevalent is DID in the population?
There have not been phenomenal prevalent studies, just to be upfront about it. There's not enough research on dissociative identity disorder. But what we have tells us that it's about as prevalent as schizophrenia or bipolar disorder. So 1% to perhaps a little bit more than 1% of the general population struggles with DID, dissociative identity disorder. Even if they
Okay.
don't know it, by the way. Most people, many people don't seek mental health services, and even if they do, so many providers have no training in trauma, much less like serious trauma, much less dissociation. So they may often not get diagnosed accurately. Even if they have DID, it may not be picked up on by and diagnosed by the clinician.
What steps are taken before diagnosing someone with dissociative identity disorder?
Hopefully, the mental health provider has been trained in the impact of trauma, including dissociation. And so hopefully they would know to ask about all kinds of symptoms. You don't just assess for DID. Hopefully, the clinician knows to assess for anxiety and depression, all kinds of things, as well as trauma exposure, whether somebody's experienced trauma. And then if they have, then they should start asking about things like what I was talking about earlier. One type of dissociation is called depersonalization, when the individual disconnects from their body. So maybe at times their body doesn't feel like it's theirs, or maybe they physically feel numb and they don't feel warmth or cold, for example, or pain. Or they may not feel emotions when they really should have emotions, and they're just emotionally flat and totally numb. And so there's a series of questions that somebody can ask. There's also some self-report measures that are screening questionnaires for dissociation. And best of all, if the clinician really has some training, they might know about what is considered the gold standard interview for dissociative disorders, called the structured clinical interview for dissociation. And hopefully they would use that. But again, unfortunately, so few clinicians have had really good evidence-based training in dissociation. They may not have somebody who asks them those questions.
Given that this is such an under-researched diagnosis, how long is the process of diagnosing someone usually, or for someone to get the correct diagnosis?
Well, in the research, it shows, depending on the study, there's most people in these studies have been in the mental health system trying to get treatment, getting treatment for something for 6 to 12 years before they're actually diagnosed with DID.
Six to
So
12 years.
6 to 12 years. So maybe they're getting treatment for depression, which is extremely common as what is called a comorbid disorder, meaning the person really does have depression. And so, the treatment might be somewhat effective for depression, but if the underlying DID is not picked up on and worked with, the treatment cannot be fully beneficial.
And is PTSD a cornerstone to a diagnosis of DID?
Most people who have DID have PTSD, or at least suffer from some of the symptoms of PTSD. So it's possible to have partial PTSD. Um, Let me just explain that a little bit. So most people who go in for treatment for childhood maltreatment, they rarely get treatment in childhood. So by the time they go in for treatment, they might be, they're often adults. And
Mhm.
it's actually more common for them to be like middle-aged adults even before DID is picked up on. So in the meantime, who knows how much treatment they've gotten and how helpful it's been. It's really a problem that there's not more effective. We've got some treatment, but that more clinicians don't know about it and don't assess for it accurately.
Well, is there any, and this is a personal question, is there anything I can do to, other than what I am currently doing, to help with that? Because that's my passion. Is this is a highly understood disorder. I was scared for years to go get help,
Yeah,
because I thought that it meant that I was lock me up insane.
I know. I know. Um, so obviously, we're in the United States. And in the US, there is still a tremendous stigma about mental illness of all sorts. And I think around the world there still is too, but obviously living in the US, I feel most confident speaking about that. Um, so a lot needs to change. And how much can any one individual change is, kind of up in the air. So as a researcher, this has been my passion too. I have been working on this for the 30 years or so of my career. One of the problems is that the psychology textbooks about, um, it depends on which school you go to, but sometimes it's called abnormal psychology or psychopathology class, where they teach about all the main disorders in the mental health book, the diagnostic manual. And those textbooks are wrong a lot of the times, or they're highly sensationalized when it comes to DID, or they emphasize that that there's a controversy about it, and they often talk about how it's overdiagnosed, according to some people out there who write a lot. It's overdiagnosed, which no research supports that. No solid prevalent studies support that. I should be a little cautious about what I say. So my research team and I know some other researchers are trying to change the psychology textbooks to reduce the stigma. Um, uh, I know that as researchers, we're trying to talk about and challenge the myths about DID. So a group of us wrote a paper that's available online free and for the Harvard Review of Psychiatry, challenging the myths about DID. I'm the first author. If I don't remember the exact name of the article anymore, a lot of articles. But if you look at Harvard Review of Psychiatry and myths about dissociative identity disorder and my last name, Brand, you should be able to find it. Anyway, so we're trying to teach the mental health field about evidence-based information about DID, not stereotypes, not stigma. And like I was inferring a little while ago, there are a group of academics who write a lot and challenge the reality of dissociation and DID. And so some of us in the dissociation field have been writing a lot of uh, articles trying to dispel the myths that that group seems to be putting out there. So going back to your question, what can you personally do, Star? I think this is a good forum. I know I'm not encouraging everybody go public with having DID because there is such stigma about it. With my own clients, I really have them think long and hard about who they share that information with, because I don't ever want somebody to think of them like you were saying you did once upon a time, like it means you have to live in a hospital or be locked up. I mean, one of my former students and I, we wrote a paper challenging the stereotype that movies put out about DID folks supposedly being aggressive to others. It's just not true. It's just not true. So,
Hmm. That brings
uh,
me to another one of my questions.
yes,
I've mentioned this before on my channel. Are people with DID more or less dangerous than the general population? I've mentioned this before, but I want the research to be confirmed by a clinician.
yeah. So I'm going to tell you my personal sense and then tell you about the research. I've been working in this field with people with DID since 1993 when I did a postdoctoral fellowship at a hospital that back then specialized in the treatment of dissociative disorders. I have never once been hurt by a patient, ever. And I worked inpatient where folks are most destabilized, most at risk. Um, so people, as I'm now going to speak as a clinician, people with DID, if they're going to hurt anybody, they almost always direct it towards themselves, as far as we know. Again, we don't have great research. There's not a single rock solid prevalent study of the prevalence of DID in the US population. There's one that took place in the state of New York many years ago. Um, but it's sad and it's shocking that there's not a better prevalence study. There's not. There have been some studies. Anyway, so what you'd really need to do to answer your question is we need to assess the whole general population or a randomized sample that's representative of the population. And then we'd have to figure out what percentage of them have DID, and of that, what percentage of them have hurt other people. When Aaliyah Weberman and I published that paper of ours where we looked at dangerousness to others in our sample, it's from a study I've been running for some years called TOP-DD studies. It stands for Treatment of Patients with Dissociative Disorders, TOP-DD. We have a website. Folks can go there. We can't make all the papers available because anytime we make a paper open to the general public, it usually costs $2,000 to $4,000 for us as researchers to pay for that paper to go to that kind of journal.
No wonder it's been so difficult for me to find sources in
Yep.
my.
Yep.
That makes so much sense.
Yeah. But back to your question, I know I still haven't answered it. In our study, we asked people what had they had interactions with the police, had they been arrested in the last I forget the time frame, I think it was 6 months to a year, and it was extraordinarily low. When they'd had interactions with police, it was often around hospitalizations, but mostly, like I said before, just to reassure people, people with DID tend to engage in self-harm, lots and lots of self-harm for some people, not everybody, but very little harm toward others. Now, there are, like in any group, I can think, generally where I live, I feel safe. But of course, there's some crime. That doesn't mean that on average, Americans tend to be extraordinarily violent, but there are some people who are. That goes for anybody on the face of the earth, including people with mental illness. As far as we know, the disorders where people are at greater risk for harm to others tends to be psychotic disorders to some extent, and substance use. When people are using substances, it alters their judgment and their behavioral control. So I know the movies often portray people like that stupid movie Split portrayed people with DID as aggressive. That is not my experience, and that is not what our current research shows is common amongst people with DID.
Okay. I've got 3 more questions that I want to try to zip through real quick.
Okay.
The first one is a question that's very near and dear to my heart. I'm really anxious to know your answer. Can you explain what integration is, and do you recommend it as the final step?
I'll try and be quick because I know we do have limited time. I could go on for this one for a while. So some clinicians use the name fusion or the word fusion. Some use integration. I'm going to talk about them as different things. So fusion is often understood to be, with DID, over time, parts becoming so integrated that they're no longer distinguishable. Them joining together so that there's not separate parts, and the person's no longer experiencing amnesia. That's a process, and it typically takes years. When I first got into the field in 1993, that was talked about as the goal for treatment. As if people could achieve that, then they'd be more stable. And so a group of us from the TOP-DD studies, there's a group of us researchers in that series of studies, we asked experts around the world in dissociative disorders how many people they had integrated. So I'll come back and define integration in a minute, but we used, I think, the word integration. Maybe we also included fusion. And the number was very, very small, even amongst the experts. And so what we took that to mean, that was like a revelation when this came out, because many trainers at conferences were teaching clinicians that fusion would be the goal, because then people are more stable and they don't have ongoing amnesia and they don't have internal conflict and war amongst different parts. Um, but I think it's actually less common than what I was taught in the beginning of the field. Now, let me go back to the word integration. What most clinicians are now trained to do or to understand, like the whole point of doing therapy for somebody with DID is to help them live in a way that they feel better about how they're living. They feel like their life is worth living over time. Often they're pretty suicidal at times. They find meaning in their day-to-day existence. If they have parts that have been battling and fighting each other, that decreases over time, and that they gradually learn about their parts and can communicate and work collaboratively with their parts. So, for example, if there's a traumatized child part, that child part gets help from inside and from the therapist, but that there are parts that look after children. Just like you hope in a functional family, there are grown-ups, parents who look after and protect children. That needs to happen inside,
It
whether
makes me so happy you say that because that's how
uh,
we feel on the inside as a family.
and so for some people that's real triggering because that's not how they experience family. So I say it could be other models. It could be a group that works well together. It could be a healthy government, if such a thing exists. It can be any kind of metaphor where everybody has rights and everybody gets listened to and their needs met as best as possible amongst disparate parts of a person. So it's complicated, but that's what I espouse. And I also believe that the client makes the choice. That I don't feel like clinicians should be pushing that agenda. Encouraging functioning, quality of living, absolutely. Stabilization of symptoms, yes. But it's really up to the individual client.
That is fantastic. I love your point of view on that. I've got two more tiny questions and then we're
Okay.
all done. Do you have any advice for someone who thinks they might have a dissociative disorder?
Yes. First of all, you are not anything like is portrayed in the movies. So you're the same person as before you were diagnosed, right? So try not to be so scared of the diagnosis and learn as much as you can about it from reliable sources. Um, there are researchers and clinicians who have written books. I've written some books. I'm not trying to push my books, but people can read quality information about the disorder. And if they're really struggling with symptoms like self-harm, suicidality, I hope they'll find a therapist who knows how to treat dissociation.
And do you have anything to say to my viewers who are already diagnosed with DID?
Yes, I hope you are working hard to find a way to take care of everybody inside. For anybody who does want to know, I've just alluded to the fact that there is a program. The research is not yet published. A group of us are writing it up now to publish what are called the interim findings, halfway through the study findings, for a program we created called Finding Solid Ground. There are two books available on, any of the places you buy books called Finding Solid Ground. One is a workbook for patients or people living with dissociation, and it doesn't have to just be DID. We wrote it so that the program helps people who have parts as well as people who don't, but who still dissociate more than what they want to do. Although, even saying that, I'm completely aware of how scary it is to dissociate less for many people. And so that process needs to happen slowly at a pace that the person can tolerate and wants to move at. They should be helping decide the pace of the work. If anybody out there is looking for a therapist, it is hard to find a therapist who has specialization in dissociation, but there's a website for the group called the International Society for the Study of Trauma and Dissociation. ISSTD. And they have a page on there about finding therapists. And so you can search for that and go in there and put your geographical location in. And hopefully there'll be some people who've signed up to have their name in there. It doesn't necessarily mean they've expressed interest in it. So by recommending you look there, I'm not supporting every one of those therapists. There's no possible way I can know all those therapists, but then check them out, see if they have openings. That's always hard. And then interview them and see if you feel like it's a good match.
Okay, wonderful. Thank you so much. I know you're so busy, Dr. Brandon. I know you have somewhere else that you need to be today. So thank you again so much for coming on my channel to talk about dissociative identity disorder.
You're welcome, Star. My pleasure.
Everybody, take good care of yourself. Make sure you take breaks and drink lots of water. And I look forward to seeing you next time.
All right.
Bye, guys.
Bye-bye.
1